Anesthesia rounds, a series of discussions of clinical problems facing the anesthesiologist. Anesthesia rounds is presented as a service to clinicians in the field of anesthesiology by Ayerst Laboratories. In this interview, Dr. Herman Turndorf, clinical professor of anesthesiology, Mount Sinai School of Medicine, and assistant director of the Department of Anesthesiology, Mount Sinai Hospital in New York, will discuss the clinical applications and value of central venous pressure monitoring. Among the questions that Dr. Turndorf will consider are the proper procedure for obtaining central venous pressure readings, clinical settings in which CVP manometry is indicated, the manner in which various clinical conditions may affect the cardiac and vascular functions reflected in the CVP measurement, the use of fluids in interpreting and treating the cause of an elevated CVP. Dr. Turndorf, would you please define central venous pressure for us? Why is this measurement made?
Central venous pressure is the measure of the effective relationship between the amount of blood flowing to the heart and the heart's capacity to handle the load put to it. It is determined by simple manometry, a cannula or catheter being inserted into the interthoracic venous system for this purpose.
How accurate is this measurement?
The measurement itself can be made with great accuracy, but for clinical purposes, it's not necessary for us to be closer than about 1 centimeter of water pressure. If by accuracy you mean how reliable is the information that we get from central venous manometry, then I think we have a more significant question and one that is worthy of more discussion and detail.
What is reflected by the central venous pressure? Which mechanisms may alter the recorded values?
The prime factor underlying the central venous pressure values that are obtained is the ability or inability of the heart to handle a volume load put upon it. If, for example, the patient has a normal heart and his central venous pressure is rising, the reasonable inference is that the volume load is too much for it. Again, if the patient's heart is failing and he has had an infusion of fluid, then a low central venous pressure implies that he needs more fluid. An extremely high central venous pressure in the face of obviously inadequate cardiac output indicates that you must augment cardiac contractility with a cardiotonic drug like isoproterenol or digitalis. You may also have to correct acid-base or electrolyte imbalance or hypoxemia.
Then there are 3 factors one must evaluate with respect to the venous pressure reading: high or low volume and heart failure.
There are 2 basic things you ask yourself each time you measure central venous pressure. Number 1, is the patient's effective blood volume adequate for his present clinical status? Let me illustrate this. Let us assume a situation in which a patient has low blood pressure and clinical signs of shock. We measure his central venous pressure and find that it's near 0, or maybe even 1 or 2 centimeters below 0. This is the classic pattern of hypovolemic shock. In this situation, we know we can infuse fluids almost as fast as we like, so long as the venous pressure remains less than 15 centimeters or so of water pressure. If the patient's blood pressure rises in response to infusion, we know that we're doing the proper thing, so long as the venous pressure remains within the limits I've stated.
The upper limit being
15 centimeters of water or less. And fluids may be safely infused up to this limit as long as the patient's clinical picture continues to improve.
What is the second possibility one bears in mind when performing central venous pressure manometry?
The second situation in which this procedure might be of value is the one in which the patient has a low cardiac output, but the cause is not defined. If you now find an elevated central venous pressure, that is to say 15 or possibly 20 or more centimeters of water pressure, then it is reasonable to conclude that the diagnosis here is not hypovolemia per se, but that the heart is failing, and that before you can correct the clinical situation, you must take steps to ensure an increase in the force of cardiac contraction. Now, this may mean, as I've said, that you have to digitalize the patient. You may have to administer drugs like isoproterenol, and you may have to correct acid-base disorders, electrolyte disorders, or you may have to correct hypoxemia. We may find, after correcting these things, that the central venous pressure starts falling and may fall to levels that are well within normal limits.
By correcting these things, do you mean causing an increase in the strength of the heart's contractions?
Yes. I mean increasing the force of myocardial contraction. In other words, if you correct heart failure from whatever cause, you could find that what you initially suspected to be hypervolemia may be, in fact, hypovolemia. In that case, you would have to then infuse fluid, even though prior to the correction of the cause of heart failure, the patient had apparently been over-transfused. This is a situation in which I think central venous pressure has great value.
In what clinical situations may these conditions occur?
The most common clinical setting for an anesthetist is that in which a patient is losing blood or has lost blood and is hypotensive. The problem that one is faced with is to determine what volume replacement should be given. How much fluid can be safely given to this patient to restore his blood pressure? Central venous pressure monitoring is of great help in this situation, but the measurement is not the sole criterion on which to base your judgment.
Does the central venous pressure suggest the volume of blood in circulation?
No. I think it's reasonable to say that there's no relationship between the central venous pressure considered as an isolated measurement and the patient's blood volume at the moment you make the measurement. When you examine the Starling curves, the reason for this should become apparent.
Then there's no accurate estimate of circulating volume that could be derived from the central venous pressure.
That's right. The central venous pressure reading is simply a measure at the moment you take it of the relationship between the amount of fluid presented to the heart and the heart's ability to handle that load. If you have a normal heart, then central venous pressure might be within normal limits at blood volume levels much above normal. If the heart is failing, central venous pressure measurements may be much above normal at levels of blood volume much below normal.
Reflecting a backing up of blood not pushed on by the heart.
That's correct.
Dr. Turndorf, where should the catheter be when central venous pressure is being measured?
The catheter should be in the central venous system, proximal to the last valve. Now that leaves us with a wide choice. Ideally, a catheter would be placed in the left atrium, but this is not practical. Therefore, it is usually placed in the right atrium or in the intrathoracic veins. Depending on what other things you're trying to measure with your central venous catheter, it could be placed in the right atrium or pulmonary artery, but this is not necessary for routine purposes.
What other purposes may be served by a catheter placed to measure central venous pressure?
The most obvious one is using the catheter for blood sampling to measure central venous oxygen content, or if you like, oxygen tension. If you do this, then the catheter must be in the right atrium and should be in or as close to the pulmonary artery as possible. Another use for the central venous catheter, and it has some value, is placement in the right ventricle during neurosurgical procedures to aspirate air that has been sucked in through the venous plexuses.
Could you elaborate on that, Dr. Turndorf?
Aspiration of air is a common occurrence during neurosurgery because of the sitting position employed and the associated negative venous pressure. In conjunction with an esophageal or precordial stethoscope to detect the onset of air embolus, this catheter may be life-saving.
What routes may be taken in placing the tip of the catheter at the proper site for central venous pressure readings?
There are 4 routes in common use. The most common, probably, is through one of the external jugular veins. The second most common, I would think, is through one of the brachial veins, either at the cephalic level or lower in the antebrachial space. The third is the infraclavicular approach, and the fourth, and I think least desirable, is through the femoral vein, placing the catheter into the inferior vena cava.
Are there areas of the central venous system in which the catheter should not be placed?
I think there are several reasons why the catheter should not be placed in the inferior vena cava. First, there is a great danger of thromboembolism in leaving the catheter in the femoral or inferior vena cava system for any length of time. Second, since the inferior vena cava is subject to pressures from surgical manipulation, artifacts will be produced more often than they would be in using the superior vena cava system. These are the major reasons for not doing this.
Which approach do you use routinely, or is there a routine approach?
There are 2 approaches that we use commonly, let's say, if not routinely. The first is through the external jugular because it's by far the simplest, and the second is through the cephalic vein in the upper arm. The jugular venous monitor presents an inconvenience. It's difficult to stabilize the catheter here during long-term central venous monitoring. The cephalic venous monitor has the advantage in long-term monitoring that it's not subject to being bumped and pulled out by accident when the patient is moved. On the other hand, the cephalic approach may require a cut down which the external jugular approach does not. I think that's important for routine monitoring. We wouldn't like to do cut-downs routinely.
How does the anesthesiologist know where the tip of the catheter is as it's being placed?
The simplest way to locate the tip of the catheter, that is to determine whether the catheter is approximately in the right place, is by watching the respiration-induced oscillations in the water column of the manometer. When the catheter is properly placed and the manometer is full, there should be a rapid free fall of fluid down the column as an indication that the tip of the catheter is patent and in the lumen of some structure. As the patient takes a breath, the central venous pressure should rapidly fall about half a centimeter of water. And secondly, cardiac pulsations should be indicated as rapid, smaller amplitude movements of the water column. So basically, there should be a continuous, large, slow amplitude change from respiration and a more rapid, shallower amplitude change from cardiac contraction. This will tell you that the catheter is in the intrathoracic venous system. If the catheter slips into the right ventricle, then of course the oscillations of the water column will be much greater because the pressure changes in the right ventricle are much higher than the pressure changes in the right atrium or in the venous system itself.
How can you tell with greater precision where you are in the system?
For that purpose, you would have to use either fluoroscopy or, with pressure manometry, a strain gauge transducer with which you can record pressure tracings. Or you might use a saline bridge to measure changes in the electrocardiogram.
What's a saline bridge?
Saline bridge is simply a column of saline that fills your catheter as an electrical conductor for transmitting cardiac electrical activity.
What units are used in the measurement of central venous pressure, Dr. Turndorf, and why are they used?
Centimeters of water are the units that are commonly used. Millimeters of mercury can be used, but if used in clinical situations, the oscillations would be so small that they would be almost unobservable. Mercury units used in conjunction with electronic recording would be reasonable because the recording instruments are very sensitive.
How do you select a baseline and otherwise standardize the procedure and its results?
Baseline should be selected so that the 0 point of your manometer is at the mid-atrial level. This would place the baseline below the mid-sternum, 1/3 of the distance from the anterior to the posterior chest wall. Now obviously, you may not always know where the mid-atrial level is from the outside, so the levels that are taken by clinicians may be the level of the suprasternal notch, the anterior or mid-axillary line. Since the absolute pressure reading is not as important as the changes in pressure which occur, it makes little difference for clinical purposes which level is selected, as long as the level is maintained. Sighting or spirit levels actually may be used to ensure that the 0 line is kept where it belongs. When a patient's position is changed, the central venous reading will be inaccurate unless the 0 line is changed in a comparable manner.
Are significant errors in technique likely to be due to equipment or to incorrect baseline or to having the tip of the catheter too far up or too far down in the venous system?
Any one of the things you've mentioned can cause an error in measurement. The commonest error, I think, is failure to put the baseline at the proper level. Possibly the second most common reason for failing to get a proper reading is damping or actually blocking of the tip of the catheter by a blood clot or by contact with a venous wall. The blood can be prevented from clotting by putting 10 milligrams of heparin into a very slow, continuous drip of saline or whatever comparable fluid you like.
Are there any contraindications to that procedure?
No, I don't believe so. I don't think heparin is contraindicated, but if you don't want to use heparin, I think that one should then keep the catheter open with a continuous but very slow drip. This can best be accomplished by using a micro-drip system. It will not interfere significantly with measurement of the central venous pressure. If the drip rate is very rapid, or if you are not using a micro-drip system and are running the drip at a moderate speed, then of course it will interfere with your central venous pressure monitoring.
What is the mechanism for that?
The mechanism there is simply one associated with connecting the bottle with its heavy water column directly to the U part of the manometer, which will then actually reflect the pressure in the bottle rather than the pressure in the patient.
What pre- or intraoperative factors might influence the central venous pressure values that are obtained? I refer here to those that would function as artifacts.
Mediastinal tumors that compress the central venous system might cause an artificially high venous pressure that is unrelated to any of the factors we've mentioned. Cardiac tamponade or pathology of this sort might also act as an artifact. So-called superior vena cava syndrome might act as an artifact. That's really a variant of hemopericardium. And possibly a pneumothorax might act as an artifact. If a patient has obstructive respiratory disease, the force of exhalation may artificially elevate the central venous pressure as well. Intraoperatively, the artifacts that may elevate the central venous pressure are of the same sort, but are iatrogenic. That is, the surgeon may be retracting and compressing the venous system. He may be rotating the heart inadvertently during retraction of the lung, things of this sort, or he may actually put a clamp across one of the large veins.
What about the effect of anesthetic agents?
Anesthetic agents in general elevate the venous pressure, but not more than a few centimeters of water. Another factor that might affect central venous pressure during operation is the use of a respirator in which the mean airway pressure is above zero. But unless you go to extremes, the influence of this on venous pressure monitoring will not be more than a few centimeters of water.
What values for central venous pressure are found in patients who are hypovolemic, hypervolemic, or normovolemic?
It would be attractive to say that someone with hypovolemia always has a low venous pressure, and someone with hypervolemia always has a high venous pressure. But the considerations which we've already discussed indicate that the problem cannot be analyzed that simply, that each situation must be taken on the basis of the specific clinical setting. Patients with hypovolemia may have normal, elevated, or low venous pressures, and patients with hypervolemia may have the same pressures. So it's important to point out again that isolated central venous pressure measurements give you no quantitative information regarding the patient's blood volume. It may give you information relating to the effective relationship between the heart and the circulating blood volume at that moment, but you cannot deduce absolute figures from this information.
Then in what situations is the isolated measurement of the central venous pressure of value?
Measurement of the venous pressure is of value in situations where a patient has lost or is expected to lose large amounts of blood or other extracellular fluids. It is also of value in patients who have cardiac disease and in whom you anticipate a serious problem. It's of great value in patients with chronic respiratory disease in whom the rales of respiratory disease may be difficult to distinguish from the rales of congestive heart failure.
Its use then is indicated when there's a need for a guide to fluid infusion. That is, the volume of fluid replacement might be based on a series of observations of central venous pressure alone.
Series, I think, is the important word. A single measurement of central venous pressure is not adequate, even when accompanied by other types of measurement, as the basis for a specific diagnosis. The patient most in need of venous pressure monitoring change their clinical status frequently. You must make repeated serial observations and interpret each of the values you get within the context of the clinical situation and what has gone before.
How would you characterize the patients for whom this procedure is most commonly indicated? What conditions would they have?
I would say they might be suffering from a very wide spectrum of disease. The sickest patients should always have venous pressure monitoring, irrespective of what their disease is. Patients having major surgery, I think, should always have central venous pressure monitoring. Obviously, cardiac and thoracic patients should also have central venous monitoring. Patients in whom you anticipate large degrees of blood loss should also have it. Patients concerning whom there is doubt about continuing blood loss post-operatively should have it. I won't go so far as some do to say that central venous manometry is indicated for every patient, because I think this is impractical. But there are those who think that every patient having an operation should have central venous pressure monitoring.
May we consider now what modalities might be used in conjunction with central venous pressure to provide a more specific diagnosis than one can obtain with central venous pressure alone?
Yes, the other modalities that must be used are first, the physician's clinical observations of the patient's state, second, arterial blood pressure, and third, urinary output. Arterial blood gases and pH should also be used whenever these are available.
What values for central venous pressure are found with cardiac failure?
With isolated cardiac failure, central venous pressures are elevated. They might be between 15 and 25 centimeters of water, or possibly higher. Let's consider as a clinical example the situation of a 59-year-old man who's had several myocardial infarctions and who comes to surgery for a gastrectomy. The initial measurement of the central venous pressure shows it to be 18 centimeters of water, which implies that his heart is borderline in its ability to handle fluids. We know this man is subject to hemorrhage. Now, in fact, after a brisk hemorrhage, the patient's venous pressure falls to a level of 5 centimeters of water. At this point, we have a patient whom we know is in heart failure, but one who has a low central venous pressure. This is a situation in which we have to be extremely careful.
What must one be alert to?
A rapid infusion of several hundred cc's of blood or other fluid in this man might raise the venous pressure to very high levels, even though we know that the amount of fluid that we put in is not equal to the amount that has been lost. We must, under such conditions, use the central venous pressure as a guide to the rate at which we should infuse fluids. Now we can take the contrary situation, that of the person who's had myocardial disease but who is not in congestive failure. He also has moderate blood loss after several hours of anesthesia. After putting 100 cc's of blood into this patient, the central venous pressure, which had been about 5, suddenly goes up to 15 centimeters of water. In this situation, I think it's fair to say that while the amount of blood that you're replacing is not equal to the amount that's been lost, unless you do something to make the patient's heart function more efficiently, you might precipitate acute pulmonary edema. And this is true even though you haven't replaced the amount of fluid that's been lost.
Because we now have indications of failure.
Now we have indications of heart failure that were not present before. The failure does not have to be an anatomic heart failure. It might be a metabolic heart failure, possibly because of a combination of acidosis from blood loss, acidosis from respiratory problems associated with the anesthetic itself, and possibly, of course, electrolyte imbalances which have occurred in the course of the surgery. If you correct these chemical imbalances, you may end up with a normally functioning heart. These very same mechanisms can occur in an otherwise normal heart.
Under what circumstances may this occur?
I seem to be stressing hemorrhagic shock. However, a patient who has had a major degree of blood loss that has continued over some time and that has been associated with sustained hypotension, either because of inability to catch up with blood loss or inability of the surgeon to control the rate of blood loss, may end up with heart failure from metabolic acidosis or even hypoxia. When blood loss is replaced, the heart will return to its normal functional curve.
Can cardiac failure occur without being manifested through elevated central venous pressure?
We'd have to say that pulmonary edema is not impossible at normal or lower than normal central venous pressure levels because, after all, blood volume problems are not the only cause of abnormal central venous pressures. But in general, a patient is not likely to go into pulmonary edema while his right-sided central venous pressure is below 15 centimeters of water.
Dr. Turndorf, in what ways are the central venous pressure values influenced by the type or rate of fluid given to any hypovolemic patient?
Over a short period of time, the type of fluid doesn't make any difference at all. Over a long period of time, the type of fluid might make a difference in the sense that saline, which may raise the venous pressure acutely, will have little long-lasting effects on central venous pressure. I think the rate of infusion, though, is more important than the type of fluid, because if fluid is infused at a rate too rapid for the heart to handle, there is a marked rapid rise in central venous pressure, and it may not fall. This pattern of results would be a good indication that you're infusing too rapidly for this patient's heart, even though you might be infusing at a rate less than the rate of fluid loss. The rate can also be used as a diagnostic test for the continuing functional ability of the heart. If a patient is being transfused at a rapid rate and you're in doubt about whether the heart is beginning to fail, a rapid infusion of 100 or 200 ml of any fluid might be tried to determine the effect on the central venous pressure. If the rise in central venous pressure is more than 5 centimeters of water and remains elevated for more than 3 or 4 minutes, I think it's reasonable to say that this heart will be failing very shortly if it's not actually failing at the time of measurement.
In what way do the central venous pressure observations indicate the advent of hemorrhagic shock in the intraoperative or postoperative period?
Let's take the example of a patient who's had an uneventful removal of a kidney and has been brought into the recovery room in good condition. But over the next hour or two, we detect such signs as coldness of the extremities, possibly some pallor, perhaps sweating, and a blood pressure which is gradually falling. The question then arises, what is the cause of the decrease in blood pressure? Is it pain? Is it due to blood loss? Or is it due to narcotics which have been administered to the patient postoperatively? What is the problem? If a central venous catheter is placed in this patient and the pressure is found to be low or is moderate and decreasing, then it's reasonable to say that this patient should be watched for blood loss and that he may have to be brought back to the operating room because of hemorrhage.
Can the central venous pressure reading indicate slower loss of fluid? For example, the intra-abdominal fluid loss that may occur with tissue insult.
Let's take the illustration of a patient with massive peritonitis from a long-standing bowel perforation. This patient has been losing fluids into his peritoneum for hours or possibly days and may come to the operating room in a state of hypotension, or he may have compensated. He may be in compensated shock. A blood pressure determination might be normal, but he might have a rapid pulse and other clinical signs of hypovolemia. The placement of a central venous pressure catheter in this patient might reveal a central venous pressure that is normal or low, but as soon as anesthesia is started, when he loses some of his vascular compensation mechanisms, the central venous pressure may take a precipitous fall to well below zero, simultaneously with a fall in blood pressure. This is the sort of patient in which massive volumes of fluid must be infused very rapidly. The volumes needed to keep this patient's blood pressure and urinary output within normal limits may be enormous by ordinary standards, and here central venous pressure is mandatory to ensure that you don't put this patient into frank pulmonary edema. Commonly, several thousand cc's of fluid per hour are needed for several hours to keep this patient stable. Obviously, this volume is far above what's given to any normal patient. If the central venous pressure monitors show pressures that stay within normal limits, there is great assurance that the therapy is being conducted properly.
In what clinical settings might this situation arise? By clinical, I refer to operative or postoperative settings.
Well, many people now believe that any major surgery is accompanied by large amounts of extracellular fluid loss, which should be replaced during the surgery, even if there isn't very much in the way of blood loss. That is, any traumatic procedure now is believed to cause the loss of relatively large amounts of extracellular fluid to the effective circulation. In this situation, as much as 10 cc's per kilogram of body weight per hour of electrolyte solutions have been recommended. Now, this is a large infusion. It means that a 70-kilogram man would have to have 700 cc's of electrolyte replaced per hour of surgery, so that in a 4-hour operation, he'll receive more than 3,000 cc's of fluid. Again, this is above what's normally thought of as reasonable. If this reasoning is accurate, it would not be safe to infuse so much fluid without a central venous monitor in place. In this situation, I would say that you must have a urinary catheter in place so that you don't overfill the bladder, and that you must watch urinary output as well.
In what clinical situations not involving surgery might the clinician consider taking a central venous pressure reading?
Situations in which blood loss is occurring or is anticipated. For example, monitoring should accompany the anticipatory treatment of a patient with a bleeding peptic ulcer, one causing relatively large amounts of blood loss, but in whom conservative treatment with respect to surgery is being considered. A patient with abnormal fluid losses from massive diarrhea, from ileostomy, or from gastric suction should be considered for central venous monitoring. If there is any possible way to do it, patients with burns should definitely have central venous monitoring.
In these situations, what might be the characteristic results of monitoring? How would they support diagnosis?
Again, the readings would be of value in distinguishing between hypotension due to deficient amounts of fluid being infused, or let's say imbalance between the amount of fluid in the patient and the vascular capacity for fluid. I'd rather not make a general statement about absolute blood volume, relative blood volume, and hypotension from other causes. If a patient with a burn is hypotensive and has a very low blood pressure, the same principles apply to him. He needs fluid therapy until his pressure comes up and urinary output comes up.
Thank you very much, Dr. Turndorf. Anesthesia Rounds is presented as a service to clinicians in the field of anesthesiology by Ayerst Laboratories.